Surgical management of retinal detachment either involves a scleral buckling, a pars plana vitrectomy, or a pneumatic retinopexy. Whenever we do a vitrectomy, we do end up using conventional oil or gas tamponades. However, they come with their own set of problems. And therefore, we decided to explore the use of fibrin glue in these cases instead of silicone oil or gas tamponades. Now, fibrin glue is a mixture of aproteinin, fibronectin, and plasminogen and has already been used in intraocular surgeries for even optic disc pit associated macular detachments. It's an agent which has already been proved to have no retinal toxicity. So, the surgical technique involves doing a complete vitrectomy like what we would have anyways done. Then, in an air-filled globe, after settling the retina, we do a laser around the break. Subsequently, again in an air-filled globe, now over the lasered break, instead of putting oil or gas, what we do is we put a drop of fibrin glue so as to cover the break, and no postoperative positioning needs to be given for this patient. So this was a 63-year-old gentleman who came to our clinic with a visual acuity of 20/200 and inferior detachment with an inferionasal break, which was noted. A complete pars plana vitrectomy was done and all the vitreous was removed. The break was marked with diathermy. Now a fluid air exchange was done and the retina was settled. After settling the retina, laser was done around the break, and after completion of the endo laser, in an air-filled globe, one drop of a thick component of fibrin glue followed by one drop of thin component of fibrin glue was placed over the break. After waiting for 5 minutes, a coagulum gets formed, and this coagulum can be easily lifted and deposited and placed with the help of a forceps to cover the break. So the idea is to ensure that the coagulum covers the break completely. After this, fluid was switched on again and the entire air was removed from the vitreous cavity. We found that the retina was completely attached with the coagulum of fibrin covering the break. We confirmed the fact that the retina was attached with the help of an intraoperative OCT. The eye was closed and post-operatively subconjunctival dexamethasone was injected to prevent any untoward inflammation the next post-operative day. On the first post-operative day, we found an attached retina with a fibrin coagulum covering the break, and the visual acuity had improved to 20/80. At 1 week, we can note that the coagulum has nearly gone away. Visual acuity has improved to 20/60, and at 2 weeks now the visual acuity is 20/60 with a completely absorbed fibrin coagulum. So fibrin glue assisted surgery is a promising technique for treatment of uncomplicated simple rhegmatogenous retinal detachments. It allows for an early visual recovery while avoiding the usual problems of gas or oil tamponade and obviates the need for a post-operative positioning. Alright, so thank you so much, judges, for allowing me to present our video.
Nice video, Dr. Mudit. I just want to know how many such cases have you performed with this glue, and what were the or the success rate or the complications that you have encountered?
All right, so now we have done close to 90 cases in the last 3 years, and in the problems that we have encountered, we have. So initially, when we first published our pilot study on that, where we had published the results of 10 patients, we had a success rate of around 80%. But now that we have fixed the criteria, what we now say is that it works best in simple, early, uncomplicated detachments.
brakes which are up to 2 disc diameters in size, because if it's a very large brake, then there's a problem of a subretinal migration of the coagulum. And brakes which are limited to 1 or 2 quadrants. It doesn't work in multiple brakes in multiple quadrants, because putting glue in multiple brakes, then the coagulums tend to coalesce with each other. So brakes limited to 1 or 2 quadrants, brakes next to each other, or small brakes up to 2 disc diameters are the ones where it works best. Once we started adhering to these criteria, in our last 50 cases, we have had 3 failures and 47 successes. The biggest advantage is that, and now in our last cases, we have actually earlier we were sometimes leaving air also. Now we even remove the air. While it may seem redundant, why do we need to even remove the air? You can just leave it like that. But even if you remove air, we just wanted to see, sometimes there may be a very small, when we do an intra-op OCT, we find a very minimal pocket of fluid at the posterior pole. But like what happens in a buckle, once your primary brake is closed, the next day that entire thing goes away. And immediately the first post-operative day itself, our patients have got a very good visual acuity to begin with. So our patients who were 2200, 2400 to begin with, post-operatively on the first day itself are 2080, 2000. By the end of 1 week, they achieve the final actual visual acuity which they otherwise would have achieved. So good post-operative, earliest possible visual recovery, no other complications of oil or gas, no positioning.
Why would the glue go subretinal if you are doing it under air? Under air, the retina is already settled.
I know.
For large breaks, I'm saying.
Yeah.
So does it? Are you afraid that it will go subretinal, or are you afraid that the temperating effect of the glue clot is the coagulum is not that much?
Even with the best possible of our drying, there is still sometimes a very minimal amount of fluid over there. And the point is that even when we inject it with the injector and just one drop goes, even then, because it's a liquid, it does slightly tend to migrate subretinally. We have actually also gone ahead and done an OCT analysis of this subretinal fibrin. In fact, it's just been accepted for publication in Retina. And where we did a serial OCT analysis of the subretinal glue which was going and showing that that glue also gets absorbed within 1 week. It's like CSR fibrin. And there was no photoreceptor damage even at 1 month, 3 months, and 6 months in all of those areas where there was a subretinal migration. But because it's a liquid, there is always a slight migration that happens.
Is there any problem with the brake location, superior brake, inferior brake? Is there any problem in outcome?
So if it's an extremely peripheral brake, I would suggest not to do a vitrectomy itself. These are brakes which are amenable to a scleral buckling. But when you are doing a vitrectomy, there is no problem. Whether it's a superior brake or an inferior brake, there has been no problem in terms of the location. It doesn't work in extremely peripheral brakes because first of all, taking your injector's needle over there and repositing or putting a coagulum or a drop over there in extreme periphery is difficult. And secondly, if it's an extremely peripheral brake, then I actually would prefer doing a buckling rather than a vitrectomy in the first case.
Just one last question, or maybe an observation. So, do you think, I don't know if you've done it, but do you freshen up the margins of your brake?
No, I don't.
You don't?
I don't do anything differently from what I conventionally do on a vitrectomy. The only thing different I do is that at the end of settling my retina, I'm doing a laser, whereas in my other conventional cases, I would have put oil or gas. Here, I just put fibrin.
And now you've stopped putting air also?
I have stopped putting air also now.
After FAX, you put glue
After
and then
FAX,
you
I put glue, I
start
wait
infusion.
for 3 minutes. After 3 minutes, I start infusion, I remove it also.
Okay.
Excellent.
All right. Thank you so much.
Thank you. We go to the next video by Dr. Gagan Bhatia, the floppy iris with a VR twist. Yeah. You want to present last?
It's not coming there.
Okay, no problem. So the Alok Sen is there.
Floppy iris. Yours is floppy iris.
Yeah.
Start the video.
A 40-year-old one-eyed man presented to us with complaints of diminution of vision in his only eye. On examination, the visual acuity was 20 by 200. He presented with a non-dilating myotic eccentric pupil and a deep anterior chamber with ectopia lentis. The pupil was pinpoint, making indirect ophthalmoscopy impossible. Ultra-wide field fundus imaging to the rescue, and we diagnosed a superior retinal detachment, and the patient was taken up for a 23-gauge vitrectomy. After a 360-degree peritomy and a 240 belt buckle, a 23-gauge infusion cannula was inserted, but couldn't be visualized due to the myotic pupil. We inserted an iris hook at the same clock hour and could manage seeing the cannula. Rest of the iris hooks were placed to expand the pupil, and we went ahead with the lensectomy. After clearing the cortical vitreous, a triamcinolone assisted complete vitrectomy along with complete base shaving was done. The breaks in the superinasal quadrant were marked with an endocautery. Before going in for fluid air exchange to maintain the pupillary dilation, we did sphincterectomies and removed all the iris hooks. Lo and behold, the errant iris constricted and draped down in the posterior segment like a whale during a closing ceremony. As the iris lay concaving into the posterior chamber, we had no option but to resort to a partial pupilloplasty with a cutter. PFCL assisted fluid air exchange was done to settle the retina, followed by retinopexy and gas tamponade. Post-op day 1, as expected in an aphakic eye, the AC was flat with a complete gas fill and the retina was well attached, though the IOP was very high. The next few days were horrifying as the IOP continued to be above 40 millimeters of mercury even on maximal medical therapy. The gas fill reduced, but the errant iris this time decided to remain stuck to the cornea, completely zipping the angle. ASOCT showed a zipped angle and the iris absolutely adherent to the cornea. The retina at this stage was well attached. To save this only seeing eye, we went ahead with a secondary procedure. The gas was removed with a cutter and the errant iris, still holding strong, stuck to the cornea. We entered the anterior chamber at a small point of separation and very gently tried to release the synechiae with a blind iris repositor. With a very controlled sweeping motion, the iris was released from the cornea in all quadrants, taking care not to damage the corneal endothelium. We also used forceps to unfurl the curled up iris tissue and help open the occluded angle. Lo and behold, the errant iris now draped down to close the show with a bow. Post-operatively, ASOCT showed a well-formed anterior chamber and a bowed down iris. The retina was stable and the IOP well controlled. With out-of-the-box thinking and timely management, we were able to manage the play of the errant iris and save this eye as this patient follows up with a well-attached retina and a post-operative best-corrected visual acuity of 20/40, though the floppy, errant iris continues to flap in the anterior chamber.
Thank you.
This is actually a common problem where in aphakic patients, if you do air fluid exchange or gas exchange, you will see that the iris is stuck to the cornea. So why do you think that this case was special or different than the rest of the cases that we encounter?
Ma'am, there were 2-3 things. One is that, yes, the iris does get stuck at when we do it becomes a flat anterior chamber, but it is not like it kind of total synechiae form. That is one. Secondly, the most challenging thing about this case was diagnosing the case, because when the patient came, there was absolutely no view of the retina, and there was no way to diagnose. So the RD was picked up on day 2. So actually on day 1 when he came with floaters. So one thing was that whether it was imperative, just go in at that time, with that hunch. But then in a one-eyed eye, which was already lost to a retinal detachment surgery elsewhere, I think it's very difficult to convince yourself, even as a patient, to go in. So secondly, the second day when ultimately because even Optos did not pick up any break or any detachment on day 1. So on day 2 when we went in, then there was this detachment. So otherwise, yes, the surgery was absolutely okay. I did not ever expect that the iris was going to get stuck like this. The iris, after the iris hooks were removed, it actually draped down almost till the ora, the iris, because one flap was very large, and that was probably the idea, to cut that little part of the iris again with the cutter, so it does not fall back and cause synechiae and then pull up the retina itself. And the third issue in this case was basically that when we going back in, so how fast to go back in, and because I didn't want that we end up again with a detachment and put in oil, because that would have been disastrous in any way. So I think those were the three challenges that I faced with this kind of patient.
Could you have done any alternative, say for example, gas tap with the AC reformation, which can be done in the OPD itself?
Yeah, did think of that, but then I had also referral with my with our glaucoma team, and they said that that would probably not help because it's already stuck, and that ASOCT is day 2, so day 2 or day 3. So they said that this is not going to get released till the time we don't go in and you don't sweep it off. So that was the thing. So I did think of doing a little bit of gas tab, but then they said that okay, wait for 3-4 days, and anyways the gas bubble started coming down, and the iris was not shifting at all, and there was no gap at all. We even tried that if we do a PI or something might work, but there was nothing that was. So usually that doesn't happen. Usually I've seen that doesn't happen. So
The reason it happened was because of the multiple cuts.
Yes, exactly.
Because there was no sphincter.
Exactly. So probably
If
because
at the
of
end
that.
of it, if you had done a
Yeah.
bit of repair, pupillary repair, two
yeah.
sutures, it would not have happened.
No, but it was very, very floppy. It was just a
I
redundant
understand.
iris. It was
Which
not even like
worsened
an
it
iris.
with the radial cuts.
Exactly, yeah.
That's where it happened.
Thank you.
Thank you. Okay. So next person is Dr. Nawazi Sheikh. Okay. So suprachoroidal hemorrhage drainage using non-valved trocar.
If my life was Disney, retina would have definitely been my Rapunzel.
The following video describes management of suprachoroidal hemorrhage using a non-valve trocar for drainage. The first patient presented with suprachoroidal hemorrhage following glaucoma filtering surgery. Patient underwent drainage using a 23-gauge non-valve trocar on post-op day 5. A stab wound was created for the introduction of the AC maintainer. The 23-gauge non-valve trocar was introduced obliquely at a distance of 5 mm from the limbus. A gush of altered and liquefied blood is noticed from the partially introduced trocar. Liquefied blood from other quadrants is displaced towards the site of the trocar. Appearance of a red fundal glow is seen at the end of surgery. Patient 2 presented with suprachoroidal hemorrhage following a glaucoma filtering surgery with a shallow anterior chamber and total cataract. Patient underwent drainage using a 23-gauge non-valve trocar on post-operative day 7. Anterior chamber was formed using a viscoelastic and the AC maintainer was introduced. The 23-gauge non-valve trocar was introduced obliquely at a distance of 4 mm from the limbus in the quadrant with the highest choroidal mount determined on pre-operative ultrasonography. Gush of altered liquefied blood and blood clots are seen from the trocar. Patient 3 presented with a suprachoroidal hemorrhage following trauma. Patient underwent drainage using a 25-gauge non-valve trocar on day 20. Localized peritomy was done, followed by the introduction of an AC maintainer. The 25-gauge non-valve trocar was obliquely introduced at 4 mm from the limbus. Gush of altered and liquefied blood was noted. Appearance of a red fundal glow was seen at the end of surgery. The trocar site was left unsutured while the peritomy was closed. On post-operative day 7, receding choroidal mound was seen in the supratemporal quadrant with the posterior pole visible. choroidal drainage include retinal apposition or kissing choroidals, uncontrolled intraocular pressure, a flat anterior chamber, or association with rheumatogenic retinal detachment. Timing of surgery is usually between 7 to 14 days when the blood has liquefied as seen on a preoperative ultrasonography, but may be done earlier depending on the indication. Trocar-based drainage is safe and effective in these patients and is a viable alternative to scleral cut-down or a posterior draining sclerotomy.
So I find that the scientific content in the video is actually lacking. I feel you should have given some pre-operative and as well as post-operative information about the patient. So it's very important to know how much was the suprachoroidal hemorrhage, how much was the liquefaction, how much was the mounts, and so the trocas that you have put at 5 millimeters from the limbus, which is actually quite close. So whether the choroidals extended up to that or not also needs to be known, and also whether any surgery was done after the drainage or only the drainage was done
Only
and left.
drainage, ma'am.
So that is also very important to
Yes,
know
ma'am.
because we need to know what is there inside.
Yes, ma'am.
Oftentimes vitreoretinal surgery is required for these patients.
Yes, ma'am.
So I think you need to add all those details
ma'am.
as well.
Most of these cases you showed were blind procedures. You just drained and closed the peritomy,
Yes, sir.
but there was no light pipe going inside and checking what was the view inside
Yes,
during
sir.
that, and why was not that done, especially in the last case. Any
Yes,
specific
sir.
reason, or you just wanted to wait and then go inside after a week? And
So basically, the last patient had presented to us quite late at 20 days. It was just a mercy attempt because it was his only seeing eye. So we were planning once we'll do this management and then assess him. On post-op day 1, that was the post-op day 7, that was the image that I had showed, the optos image. Because the choroidals were receding, we did not plan to go any further beyond that.
I'm just saying that when the anterior chamber is in place,
Yes, sir.
and you are draining a choroidal hemorrhage, you might as well put a light
Yes,
pipe and
sir.
see what's inside at the same time.
Yes, sir.
And these cases need multiple area of drainage.
Yes,
because
sir.
they are divided by septas. So that is also to be highlighted. You have
Yes,
shown
sir.
only one area of drainage. Maybe you could have done the other area of drainage also
Yes, sir.
in order to reduce the blood more.
Yes.
Comment. In your second case, you had put an ACM and there was a complicated cataract with posterior synechia
sir.
360. So how did you expect the IOP to remain? Do you expect it to go through the...
So basically, that was just digitally the IOP was checked at the end of drainage, sir. So that patient had total cataract. He had kissing choroidals basically on USD. The first patient was operated because the intraocular pressure was not being controlled. The second one had kissing choroidals, for which he was operated. At the end of once the blood was removed, we digitally checked the pressure and we ensured that the AC was being maintained with an air bubble, and then that was the point when we noted that the bleb was leaking. So the bleb was resutured and that marked the end of surgery actually.
Because the fluid can come out of the bleb.
Yes, sir.
That's why I
Yes,
asked
sir.
you
That
this.
is that is once we placed the AC maintainer was when we noticed that there was fluid coming out from the bleb. So we had to go ahead and suture the bleb as well. So that was the end of surgery for that patient.
Thank you. Next patient. Next is Dr. Divakant Mishra. Yeah, his video is titled Macular Mania.
Thank you so much. Can I? Yeah. So I'll be presenting to you macular mania, where we'll be discussing 3 interesting cases. The first is a case of a foreign body. A 12-year-old child presented to us with this case where a primary repair had already been done and presented with vitreous hemorrhage and foreign body on imaging. So after clearing the vitreous hemorrhage, we were surprised to see that foreign body was impacted right within the arcades very close to the fovea. And first we thought that the fovea is also affected, but when we started clearing the membranes, we saw the fovea was preserved, and the encapsulated foreign body had to be very carefully removed and dislodged from its location. So we used a cutter and our ILM forceps to remove these dense membranes which were stuck to these iron foreign body. And you have to note also that it is very close to the arcade and some major blood vessels. So it has to be done very carefully so that we don't injure those blood vessels and have some uncontrolled bleeding. Now I'm using the ILM forceps to gently dislodge as much as possible so that it can be picked up later on. Now when I feel that it is sufficiently dislodged, leaving a stalk behind, I enlarge my sclerotomy and use an iron body forceps to gently remove this foreign body. Now again we have to be very careful so that we don't drop the foreign body, otherwise it will be hitting the macula again. Now we gently bring out this piece of iron. That is it right there. Now I could see some wrinkling on the ILM, and this area was very close to the macula, so we went on and removed the ILM as well to prevent any ERM formation in the future. Then we have done fluid air exchange and some gentle endolaser to this area. We left the patient in air and closed the sclerotomy ports. Now this is post-op 4 weeks, and this is the OCT. The patient was maintaining around 612 vision in this case. Now the second case is a very challenging case of a macular hole. Now this patient has been operated several times before, and so he had been operated for ILM hole, macular hole twice. Then he developed total retinal detachment, for which he had been operated with oil. After SOR, he landed up with a redetachment, and at that point he presented to us. We planned a 4-port vitrectomy for him. Here you can see the detachment with the open macular hole. So here we are planning autologous retinal transplantation for this patient. I have marked a site before, but it looked a little small, so I abandoned that site and did prepare another graft site for it. I have used the curved scissors to excise the graft. Now usually these cases are done with the help of PFCL, but I faced certain challenges with using PFCL in my previous cases. So in this case I have avoided using PFCL. I have left a pedicle. I have not completely excised the graft here, and at this position I go ahead and do a partial FAX. This is because so that when we excise, completely detach the graft, then it has a lesser area of floating around in this limited fluid. Then I complete the FAX and transfer the graft under FAX. So it glides beautifully over the retinal surface. And then I slightly tuck the graft because the primary aim here is to mechanically close the hole here. Then I endolaser this area, and and another thing that is, I did a bimanual SOI where I used the close end of the forceps, ILM forceps, to hold on to the graft, because at time it, with the gush of the oil, it moves away from the host site, graft site. Now this is the post-op 1 week. This is the area, ischemic area of the graft, hyper-reflective. And after 1 month, we could see a good result with a foveal contour maintained. The patient is maintaining around 660 vision. This is the last case.
A 25-year-old male patient presented to us with sudden diminution of vision in the left eye. The vision was counting finger 1 meter. Anterior segment evaluation was normal. Posterior segment revealed a yellowish subretinal lesion involving the fovea. Certain relevant investigations were advised to the patient. The OCT revealed a large hyporeflective cystic lesion along with a hyperreflective wall with something that looked like a scolex attached to the wall of the cyst. Rest of the investigations were unremarkable. So clinical diagnosis of subretinal cysticercosis was made. Patient was put on oral steroids and vitrectomy was planned. 25 gauge 3 ports were made. Core vitrectomy was performed, and if you notice keenly, the classical undulating movements can be observed here. PVD induction was tried first without triamcinolone. Then triamcinolone assisted PVD induction was successfully done and a complete vitrectomy was performed. After the removal of vitreous, we could see a macular hole that had also developed. A small retinotomy was made at the edge of the cyst to access the subretinal space. Through this retinotomy, active extrusion was used to bring out the cyst in toto. The macular hole was more apparent at this stage. The highly compressible nature of the cyst can be appreciated here as it is removed totally through this small retinotomy. This prevents any collateral damage to the surrounding retina while it's removed. Then the cyst was eaten up at high suction and high cut rate with the help of the cutter. Fluid air exchange was performed. The subretinal inflammatory debris and the SRF were carefully removed from the retinotomy that was made earlier. SF6 gas was then injected. Gas was then so we got good outcomes after the surgery, a vision of 618, and the hole was closed.
So we have not done any extra maneuvers to close the hole. The area felt very febrile, but luckily it closed on its own. And one last point for this patient after another 2 months developed optic disc edema in the other eye. He went to a neurologist and the counseling was, the neurologist painted a very grim picture and the patient committed suicide after a couple of months. So yeah.
The nice cases, all 3 different cases with excellent surgical treatment you have shown. Only 2 small tips I would have for the audience. One is that in the first case that foreign body capsule which you have dissected, so it is good to dissect from the top of the foreign body, but caution is that you should not dissect it from the retinal surface because it is very adherent to the retinal surface and you can end up with break. And second thing is, don't use ILM forceps for the foreign body, it will get spoiled and you won't be able to use it again.
It was an old forceps I keep for these things.
Devakan, 2 tips for you also. Very honest feedback. The cases are wonderful. The video recording system is also very good. But no fast forwarding, please. It is actually a visual disturbance for the audience and more for the judges also.
Right.
You edit small clips and then patch them together. Fast forwarding creates a disturbance which is not required. Secondly, if you are competing at a highest level, there should be a certain homogeneity of the presentation. The last clip had a voiceover and the first 2 clips did not have a voiceover. These are practical tips for everybody presenting a video. So either you present with the mic or either the whole video should have a voiceover. Just a feedback.
Thank you, sir.
Thank you.
Okay, so we go to the next one. Dr. Naresh Babu. The video is titled Subretinal Gliosis Removal, an Unconventional Approach to Proliferative Vitreoretinopathy.
Hello everyone. It is a unique, unconventional technique of removal of subretinal gliosis without making retinotomy. After making 3 ports in the pars plana region, a complete vitrectomy was carried out. During the vitrectomy, an extensive subretinal gliosis could be noted in the nasal region and around the disc. One 25 gauge valve port was introduced to the subretinal plane at a distance of 10 mm from the limbus, keeping the trocar 15 degree. Then, with the help of a MaxGrip forceps and with vitrectomy cutter, all the subretinal gliotic bands were removed via the 4th valve port. Finally, the napkin ring-like band around the disc was also removed. The final outcome after removing all the subretinal bands meticulously was encouraging. Rest of the preretinal PVR bands were removed via the conventional pars plana ports. The preretinal membrane over the foveal region was meticulously dissected using a Thanos.
All the adherent peripheral vitreous sheets were removed 360 degree to release any undue traction and for settling the retina adequately. Under PFCL tamponade, ILM was stained using heavy BBG dye. Then an extensive arcade to arcade ILM peeling was done.
Finally, the case was closed under oil tamponade.
This technique of removal of PVR bands via subretinal route can be useful in cases of extensive subretinal gliosis. Hope you all have liked the video. Thank you.
So it's a very nice, very excellent and heroic surgery, I would say. What is the first of all, what I would like to know is what are the indications when you advise that this technique should be done, and what are the specific advantages of doing this over our conventional way of removing the membranes?
So first is now default wherever there is a bullous RD with subretinal band, this is our technique. All of us follow this. The main advantage is when you have got a napkin ring, you don't need to make a hole the retinotomy adjacent to the disc. Because if the retina is stiff and if you're making a retinotomy, we all know that there is a chance of migration of PFCL. Here no retinotomy happened except for the last one when we are peeling the fixed fold. Otherwise no retinotomy is required in this case actually. So there is no danger of any PFCL or any migration of oil under the retina during the entire procedure.
But there were a lot of pre-retinal membranes which had to be removed after the
Yes.
removal of the bands also.
Yes.
So in case you end up causing an iatrogenic break or causing a retinotomy, then you have an access to go subretinally and remove the membranes is what I was
No,
thinking.
like actually now we have modified the technique in the sense we don't do a complete vitrectomy. As soon as we enter, first thing we do is removing the membrane because that vitreous inside acts like a pulling things so that the retina remains bullous. And after that, we do the vitrectomy. In case if iatrogenic, retinotomy happens, I think we have to be careful. That's the only thing.
When you injected that trocar at 10 mm from the limbus, your light pipe was not inside. You injected from the outside only.
Yeah, outside,
so
but
won't be
after.
a good idea having a light pipe
No,
inside?
no, no. We have light pipe because after inserting for 2 millimeter, then we put the light and we see through and then go inside. It's guided.
And one question, sir. Have you encountered any iatrogenic break while doing the subretinal surgery?
No, no, no. Like there are other techniques. If it is not bullous, what we do is you inject subretinally the BSS with the help of a 40 gauge cannula, and you make the retina much more bullous so that we'll have a lot of space to work under. And when we are doing the stroker through 13 millimeters, never we encountered any suprachoroidal hemorrhage or choroidal bleed. Never it happened.
Probably it looks good in your hands.
No, no, no. It is reproducible actually. It is not a great technique. In fact, I want to credit Dr. McKimmer for this actually. It's not our imagination or this is there in Ron Michaels. This was done by McKimmer in his pre-vitrectomy era. So he has done this basically, going and removing from the under surface of the retina with the help of indirect ophthalmoscope before vitrectomy.
So I would think this technique would be useful for reaching subretinal bands which are normally cannot be reached with your normal retinotomy, which you do in the sclerotomy, in the clocker of the sclerotomy. So sometimes if they are too much inferior at around 12 o'clock or 6 o'clock or on the nasal side, then this would be a better idea. Thank you. Thank you. So next presenter is Dr. Aisha Khanum. Encounter with the giant.
Hello everyone, I'm fellow Vitro Retina. So video please.
Are you shaving your head? We're going on an epic adventure, Morty. What? Get retinal tears, Morty. Fresh with bleed, old detachments, with macular hole. What does shaving your head have to do with... Why do we have to do anything, Morty? I don't know. That's good, Morty. Find your motivation. We have to make choices, and we have to face the consequences. We're going to the 9 realms. Oh! When it comes to tears, Morty, it's not all about tears. It's about vitreous. Vitreous! So put your to ringer and cut all you can like a piranha in action. Oh my god! Look at the size of the tray! That is that a macular hole? I want to say that size doesn't matter, but here I will agree with you. But worrying doesn't suit us retinal surgeons. Sometimes we just have to be creative. Let's cut a piece of this interior lip, and we will use it as an autograft for our macular hole. Tuck it nicely. Now you have to put some perfluorocarbon. Stabilize your posterior pole. Ditormous the edges. An endolaser like his vision depends on it, because it does. Do your perfluorocarbon and siliconol exchange, and hope for the best. Sometimes science is more art than science, Morty. A lot of people don't get that. Let's look at the post-ops. These are our post-op day 1 and post-op day 7 scans. We can see our retinal autograft here, and the retina is on. I might as well say the surgery was a success. Moving on to another adventure. Fast, but not furious. This is a child with Stickler syndrome. He came to us with sudden loss of vision for 1 day. We planned immediate vitreoretinal surgery. A good, steady, thorough vitrectomy saves your day, any day. You have to set your parameters right. High, cut rate, and low, vacuum, so that your retina behaves. Here we are trimming the horns of the GRT. Rest, you know the drill. Put perfluorocarbon to flatten the retina. 360-degree endolaser. Perfluorocarbon and siliconol exchange, and your eye is set. And ladies and gentlemen, that's what we call a good outcome. in our next adventure. I'll paint you the picture first.
And your old child has come to our clinic status postornius laurel tear repair. This is his abuse scan, and you'll be of service here.
Well, let me check my list of powers and weaknesses. Ability to do anything, but only whenever I want. Yeah, it sounds like a job for me. What we could see at this point was a bolus detachment, so we chose a 20 gauge candela. Next step was vitreous debulking. Membrane dissection to free the edges was started. What we realized on our way, that the nasal retina continued anteriorly with no edge whatsoever, exactly towards the site of corneoscleral repair. Now we have to create the edge, and that's why nasal retinectomy is being done. Went with perfluorocarbon to unfurl the retina. But then this happened. Watch closely.
So we can see Pierce
This
here
clearly
escaping
indicates towards
downstairs.
leftover traction.
Down.
Hence further search for membranes commenced. We saw some subretinal vitreous in heme earlier, so it would not be outrageous to assume the presence of subretinal gliosis and vitreoretinopathy. For the moment of truth now, on re-injecting perfluorocarbon, look at this beauty unfolding. Finishing the endolaser under the perfluorocarbon. The perfluoro and siliconol exchange, and the case was closed. For the post-ops, I'll let the picture speak for itself. What do we learn here? To live is to risk it all. Otherwise, you're just an inert chunk of randomly assembled molecules drifting wherever the universe blows you. Kids, for the last show.
What is so special about it, sir?
Here you are wrong. All giant retinal tears are special, and we should never take things for granted. This surgery is to reinforce the basic steps that we have seen till now. Port for chandelier illumination is being made. Corvitrectomy is done. Trimming of the horns help us ensure that there are no residual vitreous strands. For peripheral vitrectomy, intravitreal triamcinolone acetonide can improve our visualization. Ensure a thorough peripheral vitrectomy. Perfluorocarbon is injected using a dual-bore cannula. Once the retina is enfolded, endolaser is done under perfluorocarbon. Perfluorocarbon and siliconol exchange is done. I have noticed less slippage of retina with this technique. These are the post-op results of this patient. All right, listen to me, Morty. I know that these situations can be intimidating. Meeting them head on, charging right into them like a bull. That's how we grow. Don't ever forget your basics. Don't be the bird who'll fall once the branch breaks.
So I'm sure all the young people would have enjoyed the cartoons, and the music was but my generation music.
I'm glad you liked it, ma'am.
So good, good cases you have shown, but I didn't actually catch exactly what was special about these cases that you have shown.
So, ma'am, we've tried to cover, first of all, basics. At the last, we tried to revise all the basic steps which are learned throughout the surgery. And the first three cases, we try to show various ways GRT can present with us. Like in cases of Stickler syndrome, where it is very important to remove the vitreous, as vitreous is disease. If we leave anything behind, their chances of recurrent detachment and PVRs are very high. And the third case, it came to us kind of as a surprise because the repair was done elsewhere. So when we went inside, the retina itself was stitched to the corneoscleral limbal junction. So, and then to create a retinectomy, create an edge, and then flatten the retina. And then when the retina was not flattening out, try to find out the presence of subretinal PVR and remove it. So all these things were decided on the spot and weren't kind of planned. So yeah, so management.
How did you get to manage to get this voice of Morty?
Yeah, so yeah, I've used
Is it AI based?
AI based.
Yeah, super innovative and very challenging cases. The only thing I observed was that you were super aggressive with your laser. I mean, it's natural at the end of a difficult surgery, you want to do as much laser as you want, but I felt it was a little more. Maybe there were 6 to 7 rows of
Yeah,
laser in
we
every case.
So we did not see any kind of complications happening because of the laser later, but we have seen that in the end there are less detachments or less kind of, it shows it had better outcomes. That what we noticed with this many laser. And in the end, when we are wondering whether the PVR rate, because of GRT, of course the PVR rates would be high. These kind of lasers help us secure the retina more. That's what we felt.
Innovative
More laser
approach.
will lead to more PVR in these cases. It's the
GRT
opposite, more
itself
breaks.
also, sir. So yeah.
Anyways, excellent video.
Yeah, thank you so much, sir. Thank you.
Can I call Dr. Meenakshi Mahesh now? Is she here? For a video titled The One-Eyed Fit, All That It Takes to Save an Eye.
Good afternoon, everyone.
Neuroblastoma, one of the most common ocular tumors in children, can have devastating outcomes if not treated on time. Many children can lose both their eyes to the disease. Here is a case of one of our warrior babies and the fight that prevailed to save his only seeing eye. A 2-month-old boy with family history of retinoblastoma presented to us. His left eye was enucleated and right eye showed group E retinoblastoma with exudative retinal detachment. He underwent 6 cycles of systemic chemotherapy and TTT to the active tumor. At age of 18 months, tumor was stable, but he presented with a legmatogenous retinal detachment with a peripheral break. A scleral buckling was performed for the same, and in 4 years, he underwent lens aspiration with IOL. However, at 7 years, he had a recurrent RD, so we planned a vitrectomy with drainage retinotomy, endo laser with silicone oil tamponade. Tricot-assisted PVD induction was done, followed by completion of the vitrectomy. Following which PBG dye-assisted eyelid peeling was done. As the break was not identified, a drainage retinotomy was performed, followed by fluid air exchange. Endolaser was done around the site of drainage retinotomy and around the site of calcium plaque, which was the suspected site of break. Unfortunately, 4 months later, the RD persisted. The yellow star shows the site of suspected break, and the white arrow shows the area of lifted retina. With not many options left, we thought a macular buckle would save the eye. The primary scleral buckle was removed and the macular buckle was placed in position. This shows the surgeon indenting to make sure that the break was on the buccal summit. To our dismay, however, the RD persisted. Relaxing retinectomy was not an option considering the large area to be dissected and the tumor involvement. Our final strike was a tumor fracture 4 months later. The plaque over the site of suspected break was dissected carefully and released with forceps and the cutter. Hemostasis was achieved, followed by fluid-air exchange, endolaser around the site of break, and a silicone oil tamponade. Although our path to success was very long, did we succeed? We did emerge victorious. This was the immediate post-op OCT. And this was the OCT 18 months later, where the child regained a visual acuity of 20 by 120, and this remains for a follow-up of almost 7 years. This was our victorious tale of the one-eyed fight. We were also able to save both eyes of his younger sibling with retinoblastoma due to timely intervention and surgery. Thank you for watching.
Quite a tough case and very nicely managed. What I would like to know is why was there such a gap between the two surgeries, like 4 months and very long gaps were there?
Ma'am, so this child is based out of Indonesia. So we have treated him periodically as per how he has followed up. That is why we had the gap. And the child, since this child we have treated for the tumor per se, we were quite confident that the activity, we were able to manage the activity also. So none of these surgeries were under topotecan infusion also, because the tumor was well controlled. The issue was that it was a one-eyed patient and the RD kept persisting. So that's how we have followed up.
Could you finally identify why it was persisting?
So sir, the site of break, like we had first thought, was under the calcium plaque. So that's why even like when we indented and saw, the macular buccal was able to settle it, but somehow it was not holding up because the plaque was lifting the retina up. So our only option was to relieve the traction of the plaque and then settle that area of the plaque. So the plaque still persists over the break, which is plugging the break, but the traction from the rest of the plaque is avoided. That's why.
Just one small suggestion during videos, like we should avoid inserting full slides, full written slides, because that's the whole idea of a video. It should go with the flow. So maybe that material could be superimposed with a video or a picture. Just a tip, makes it more interesting.
Sure.
Nice case.
Yeah, thank you.
Actually, 1 second. This was an excellent case. Which recording system do you use?
So we have an Aikigami based recording system.
Aikigami
so
is very good.
Yes,
It's very good. But unfortunately, it's not translating into your videos.
Yes, I know.
Because of your settings. So if you are in the OR, the common thing when the camera was focused on the interior segment, I'm telling you because 50% of your marks are presentation and 50 marks are scientific content. So it's very important to how to present it. So if you are presenting at a competitive level, you can see your interior segment is of natural hue. The conjunctival vessels, the cornea is looking good. But when you go in the endolight and see the retina, it's all bluish hue.
Yes.
And that is because of 2 reasons. First, you have not adjusted the white balance before starting the recording. And the second thing is when you go in the vitreous cavity, it is a low light condition.
Right.
And in a low light condition, you have to increase the temperature, the K reading, the Kelvin temperature. You have not done that. So you are using the same interior segments as a very good camera and using that for posterior segment recording, and that does not work. And the picture quality is a little subpar.
So the white balance we did fix, but the temperature we did not. Yes, that is
very important.
Issue, yes.
The second thing is, apart from that, the overall illumination of the video is less. So either you increase the illumination, the brightness knob on the Ikigami video recording system on the system. If it is still very dark, you cannot increase it indefinitely because it will increase the noise also.
Yes.
The pixels also. Use a chandelier light or use a secondary illumination which is more brighter than the currently the one currently used. So these are some tips. Thank you so
Thank
much.
you, sir.
VT449, please.
If my life was Disney, Retina would have definitely been my Rapunzel. And this video is about saving her tangles from the jaws of incarceration. A worrisome situation caused usually by trauma in my cases were caused iatrogenically by two different subspecialties of ophthalmology, presenting management of iatrogenic retinal incarcerations, rescuing Rapunzel. My first case came from a retina department where an attempted scleral buckling for pediatric retinal detachment caused a superior scleral perforation with retinal incarceration. Surgery began with core vitrectomy and peripheral vitrectomy. SRF drainage through superior break delineated the incarceration adjacent to break with retinal folds radiating from it. Further PVD was attempted to have a tractional pull on the retina. This traction had to be very careful so as to avoid ripping open the causative break. After repeated, careful and very slow traction on attached vitreous from suction of cutter, we can see my tangle Rapunzel getting released and freely fluttering. It was followed by fluid air exchange and endolaser of break and perforation site, which can be clearly seen in yellow. Followed by 360-degree endolaser circlage, followed by silicone oil injection. At 3 weeks, patient's vision improved from PL positive to 6/60 in an oil-filled eye with normal IOP. Second incarceration came from anterior segment, where a peribulbar block before cataract surgery caused a paramacular scleral perforation with retinal incarceration. I proceeded with core and peripheral vitrectomy to clear the vitreous bleed and visualize the retina. The incarceration was pretty obviously visible here. Because of its proximity to fovea, a tractional release like previous case had a risk of macular rip. Hence, here the edge opposite to macula was diathermized and carefully suctioned with cutter, without cutting, which led to fraying away of the cauterized retina. Thus giving me my untangled Rapunzel, and here you can see her edges freely fluttering. It was followed by fluid air exchange. Next challenge was to deliver extremely precise laser to the macular edge so that not only the fovea remains unlasered, but also the expansion of laser reaction post-op spares that vision giver. It was followed by 360-degree laser circlage and silicone oil injection. At 2 weeks, patient improved from hand movement to a 6/60 in oil-filled eye with normal IOP. And this, ladies and gentlemen, was how I rescued the love of my life.
Thank you.
Why Rapunzel?
It was, sir, it was, the movie's name is Tangled.
Yeah.
And in my cases, the retina was tangled. And because retina is my
Not
special.
tangled, incarcerated.
So tangled, incarcerated, I mean, that's where I drew the inspiration from.
Excellent surgery.
Good surgeries, yeah.
Thank you, sir.
Your two things to improve your the first video especially. You are doing a lot of peripheral work. So recording in macular surgery is very simple. Your light pipe is very close to the retina. So what happens is it causes a lot of blooming in the area of interest of surgery. It's good and convenient for you, I agree, and that's the most important part. But the recording comes subpar. I cannot see anything in the area you are operating or you're peeling. So you have to keep your light pipe a little retracted towards the ports, so it acts as a chandelier effect. So it eliminates the whole vitreous cavity. The recording will the quality will improve manifold. And
So,
second, the background music is a little loud. Am I lacking a little less and more of voiceover?
Sir, I absolutely agree with you on the first thing. Just that I was not planning on. I mean, I was not planning on putting this case up for a video, but when I went back, I saw this was the best I had.
Thank you.
Thank you, sir.
Can I call the next presenter, Dr. Renu Dr. Renu, Taming the Giant.
Thank you, madam.
Hello everyone. Here we present the management of a giant macular hole in a 30-year-old Alport syndrome patient. She presented with progressive dimness of vision in right eye for last 6 months that was severely affecting her day-to-day life activities. On examination, her best corrected vision in right eye was 20/400 on Snellen's chart. She had prominent anterior lentigonus, and on dilative fundoscopy, a giant-sized full-thickness macular hole of 1791 micron was observed. We electively planned for combined cataract extraction with PCIOL implantation along with managing the full-thickness macular hole in this case. After making 3 conventional 25 gauge ports, a thorough pars plana vitrectomy was carried out. Under direct visualization, the enormous size of the hole was reconfirmed. Then, for PVD induction, routine tricot was done, and with the help of vitrectomy cutter and Thanos, a meticulous attempt for PVD induction was tried. But even with the best efforts, it was found difficult due to its anomalous extreme adherence to the inner retinal layers. Due to failed attempt of PVD induction, the tricot wash was repeated, and fortunately on this occasion PVD was induced completely from the disc and vitrectomy was completed all around the macula and the posterior pole. After completing the vitrectomy, PFCL was injected, and under PFCL the ILM was tried to stain with heavy BBG dye. Even after repeated staining, the inner retinal layer was sparsely stained. Then, with the help of forceps, a complete ILM peeling was tried. But probably due to type 4 collagen defect, ILM was found to be absent here. Due to the excessively large dimensions of the hole, the defect was decided to be closed using retinal autograft. A suitable site in superonasal quadrant near the equator was selected for donor site, and the autograft was marked using endolaser.
Then, with the help of Thanos and ILM peeling forceps, the retinal autograft was mobilized carefully, keeping the inner retinal surface above, and the dissected autograft was meticulously shifted from the donor side to the full thickness macular hole defect region. The final outcome after the closure of the hole with the autograft was encouraging. Next, the donor area was further secured with a barrage laser around it. Then fluid air exchange was done to completely dry out the retina and specifically the foveal region for better macular hole closure. Finally, the case was closed using 2 cc of 100% SF6 gas injection for adequate tamponade. On 6-month follow-up, the graft was noted adequately covering the defect and a type 2A closure was achieved. The patient was happy with her improved vision. This unique video may help managing these challenging situations in future. Hope you all have liked the video. Thank you.
That is an interesting case. Why for the retinal autograft, why did you not choose to do a bimanual technique? Because there was a bit of a struggle for the retinal autograft to cut that and then shift it to the macula. And in that shifting, there is always that retinal autograft gets bunched up, and sometimes it is difficult to maintain the orientation. So with a bimanual, it's much easier. So was there any specific reason?
No particular reason, madam. In this case, yeah, some bleed also was there, and some difficulties were there. A bimanual would have made it slightly easier to handle the tissue. That's true.
Or injecting subretinal fluid to make it a little more.
More, yeah, and localized detachment, and that is also I have done some cases like that also. So that makes it easier.
So this ILM was absent means exactly what? Because is it reported anywhere? That
Yes, madam. Previously, there has been case reports of failed macular surgeries and absence of ILM staining in during the surgery of these giant macular holes in Alports, because the defect is in the type 4 collagen, which is part of this interface, vitreoretinal interface. So that causes this. And in the previous reports, with normal routine surgery, they were not able to peel the ILMP, and they proceeded with FAE and SF6, and the reports of failure is reported. So that's why I went ahead with a primary autograft in this case.
Why you have stained the ILM under PFCL in this case?
That's a routine thing we do for these cases. We can immediately, like, there's no waiting time, and anyway, like, I'm planning to shift the graft under the PFCL.
And which
so
forceps you have used to drag the retinal flap?
End grasping.
You mentioned heavy BBG. So did you mix it with something
With
to make
with
it heavy?
10% DNS, madam, in 2:1 ratio, 0.05% BBG with 1 part of 10% DNS.
Your video needs a little bit editing, otherwise it's excellent.
Okay, thank you, sir.
Okay, so we go to the next one, Dr. Giriraj Vibhute, recreational lasers, the good, the bad, and the ugly.
We have to admit that all of us have enjoyed this at some part in our life, be it in a disco or be it on the street, for a function, for a procession,
It feels so much fun, isn't it? But we may end up like this the next day. These are the stories of our patients who presented to us with loss of vision in their eye following exposure to the laser light. We have a case series of around 10 patients who presented to us immediately after these festive season. So we are sharing with you 3 such representative cases. As you could see on the fundus photo, OCT and the intraoperative view, that the damage is exactly located at the fovea. What we have to do now? The patient was posted for vitrectomy surgery. You can see the core vitrectomy being done, and you can notice again the hemorrhage located at the fovea. Triamcinolone is used for PVD induction. Careful PVD induction is done and vitrectomy completed. BBG dye is used to stain the ILM. Excess dye is removed with the help of cutter. The vitreous sheet which is present over the macula removed carefully. You can see the sticky nature of the vitreous in a young patient. But we could remove the vitreous sheet carefully and successfully. Flat lens is used for the ILM peeling. Pinch and peel technique is used to start the ILM peel. Flaps are lifted and ILM peeling is gradually done in a circular fashion. You can notice the blood which is stuck to the inner aspect of the ILM. Later on, the reflux function of the cutter is used to wash the collected blood, and to our relief, healthy fovea was noted underneath. Various color channels of the 3D visualization system are helpful in identifying the ILM edges. So this is the end view, and the patient eye was filled with air. In the post-op fundus picture, we can see complete recovery, and this patient gained post-op 6/6 partial visual acuity at 1 week post-op. Coming to case 2, similar patient who presented to us a day after his exposure to the laser lights. Similar fundus finding involving the fovea, sub-ILM bleed was confirmed on the OCT, PVD was induced, BBG was used to stain the ILM in a similar fashion. This time intraoperative OCT was used again to confirm during the surgery. By pinch and peel technique, ILM peeling was done. Again you can notice the location of the blood being in the sub-ILM space, it being adherent to the posterior aspect of the ILM. In a circular fashion, ILM peeling completed. Again, the reflux function was used to wash the excessive blood. And underneath, luckily, no macular hole was noted as confirmed by the intraoperative OCT. Again, the patient was left air-filled. Post-operatively, this patient recovered well with 6/9 vision. Coming to the third case of the series, this patient presented to us 10 days after the injury, and we can already see that the blood is getting dehemoglobinized. So in a similar manner, we injected triamcinolone, PVD was induced, BBG dye was used. You can see how clearly the 3D visualization provides us with the view to perform the ILM peeling. The monochrome color channel which is available gives us with great contrast to see the ILM edge more confidently and more clearly. ILM peeling is gradually completed all along the sub-ILM bleed. You can notice the altered nature of the blood, and again it is washed with the reflex. The point to notice is in all our patients in our case series, none of them had significant injury to the underlying fovea and all of them recovered with a great vision. This is the post-op OCT and patient gained 6/6 vision. Let's hear what the patient has to say.
ಡಿಜೆ ಮೆರವಣಿಗೆ ಹೋಗಿದ್ದೆ. ಡಿಜೆ ಮೆರವಣಿಗೆ ಹೋದಾಗ ಆ ಡಿಜೆ ಲೈಟ್ಸ್ ಇರ್ತಾರೆ, ಲೇಸರ್ ಲೈಟ್ಸ್, ಅದು ನನ್ನ ಕಣ್ಣಿಗೆ ಬಿದ್ದು ಬ್ಲೀಡಿಂಗ್ ಆಯಿತು. ಅದರಿಂದ ಈಗ ನನಗೆ ಕಣ್ಣಿಗೆ ಪ್ರಾಬ್ಲಮ್ ಆಗಿತ್ತು, ಕಣ್ಣು ಕಾಣಿಸ್ತಿಲ್ಲ ಆಗಿತ್ತು. ಮತ್ತು ಆಪರೇಷನ್ ಮಾಡ್ಕೊಂಡೆ. ಆಪರೇಷನ್ ಮಾಡ್ಕೊಂಡಿದ್ದೆ ಈಗ ನನಗೆ ಸ್ವಲ್ಪ ಕಣ್ಣು ಕಾಣಿಸ್ತಿದೆ. ಸೊ ದಯವಿಟ್ಟು ಮೆರವಣಿಗೆ ಹೋಗ್ಬೇಕಾದ್ರೆ ಡಿಜೆ ಲೈಟ್ಸ್ ಇದ್ದಾಗ ಕೇರ್ಫುಲ್ ಆಗಿ.
Okay, good cases, yeah, nice. What is your hypothesis why this subialam hemorrhage has developed because of laser?
Ma'am, this was seen post Ganesha festival. All the patients had similar history. They had been to a procession. So it's not just subialam bleed. Of the 13 cases which we saw in the month of September this last year, so all of them had varied presentations, of which 7 patients had this subialam bleed. Some patients had just foveal cyst. One more patient had only outer retinal atrophy. So the patients who have had subialam bleed in such cases are doing well with the ILM peel surgery. That's what is the aim of showing this video.
No, I understand that, but subialam hemorrhage is generally because of trauma. So here there is no trauma to the eye. It is just some laser,
Yeah.
which possibly they have seen the laser. That you do not know whether they have.
No, it
actually
is
shared.
one day after the history. Immediately next day, they are all presenting with this thing. And one more point which I want to say is all the cases, it is happening only in one eye. They have had the history of looking directly at the lasers. Next day, they are coming with loss of vision in one eye. Other eye is not having this problem. So mechanisms are still, we need to know. Even I'm not sure why this is happening. So that's what the aim of this.
Maybe it would have been good to include that in the video also. That what is your hypothesis? What is so interesting? I mean, they're definitely interesting cases, no doubt.
Yeah.
But what is the reason why it has happened? Maybe
Yeah.
it would have made it a little bit more interesting.
Yes, ma'am. Awareness is the only aim. People
Actually,
should know.
in continuation with that, it is very, very difficult to correlate this presentation with a laser, because lasers, we have seen patients, it causes a burn.
Okay.
Causes a burn in a very random fashion in the macula, like a serpiginous-like choroiditis kind of a picture in a pattern. Now this, somebody coming from a festival, so there's a lot of excitement, lot of dancing, and although sometimes raised ICT, sometimes excessive Valsalva can induce something like this, which is common in a party, in a disco, in a festival.
Yeah.
So there are ample literature reports of laser-pointed induced subialam bleeds. And
Okay.
The hypothesis is not clear, but there are ample reports.
And we are not sure what kind of lasers these people are using. It is all unregulated. Nowadays, it is increasing day by day. So hundreds of lasers, they are moving in all the directions.
Surprisingly, the fovea was healthy in all of your
Yeah.
cases underneath.
I
That
think 2 weeks back there was a report of Indigo pilot who is getting affected because of this laser, and he couldn't
Yes,
fly that
yes,
day.
we read
Yeah,
that.
it is there
Yeah,
in news. Yes, sir.
Nice cases.
Thank you.
So I call upon the next presenter, Dr. Hema VK. So her video is titled "Slippage Not Forgiven: Do's and Don'ts in Intraocular Foreign Body Removal."
Thus aiming at enlightening the audience for an effortless removal of IOFP. Our first case is a case of 36-year-old car mechanic with a vision of 612. CT scan and B scan revealed an intraocular foreign body. Anterior segment examination showed a corneal tear, sphincter injury, and a traumatic cataract. The lens aspiration was done, which revealed a pre-existing large posterior capsular rent. An intraocular foreign body was seen in infratemporal quadrant with adjacent sclerosed retinal vessels. Vitreous was generally cleared all around the intraocular foreign body, and the foreign body was allowed to gently fall on the retina all on its own. A 23-gauge magnet was inserted. The intraocular foreign body was safely lifted from the surface of the retina. A magnet helps us to hold and safely lift the foreign body without a fall than using a forceps. You can see the intraocular foreign body is brought behind the pre-existing PC rent without a fall. The IOFB was removed using an iris claw holding forceps through the same pre-existing PC rent. As this was a clean case without much sign of infection, we implanted an intraocular lens. Through this case, we highlight that the magnet gives us a firm grip of intraocular foreign body without causing a fall than using a forceps. The second point is that in cases like this where there is a pre-existing large PC rent, the same rent can be used as a route for the removal of intraocular foreign body than using a pars plana route. Our second case is a case of 32-year-old male patient with a history of penetrating scleral wound repaired 1 month back. Intraocular foreign body was missed during the primary surgery. The patient presented with vitritis and repeat P-scan revealed an IOFB. He had a vision of 612. Vitrectomy revealed an intraocular foreign body. As this patient had a clear lens with a small intraocular foreign body, our plan was to go through pars plana route so that the crystalline lens is not disturbed. We did it bimanually using a magnet and a forceps with the aid of a chandelier illumination. A 19-gauge magnet used in this case serves in two ways: lifting the IOFB without a fall and aligning the IOFB on the forceps in the correct axis for its easy removal. This case highlights the importance of CT imaging in suspicious case of metallic foreign body even if B-scan is normal. The bimanual method helps us in removal of IOFB through pars plana route without damaging the crystalline lens. Magnet is an excellent tool serving multiple functions in an intraocular foreign body removal. This is a case of a 64-year-old male patient with traumatic cataract and ruptured capsule following an injury at the construction site. The CT scan revealed a large intraocular foreign body. The traumatic cataract was aspirated and vitreous hemorrhage was cleared. But there was no signs of intraocular foreign body internally. We explored externally at the site of primary scleral tear repair. A thorough exploration revealed no IOFB externally also. Now we have a situation with an IOFB in the CT scan but no signs internally or externally. The pars plana region was cleared. We could see a metallic shine at the region of pars plana. We nudged the area and an intraocular foreign body was noticed. It was grasped with a 3-prong forceps and was externalized slowly in a controlled manner. At last, here comes a large intraocular foreign body. The lesson learned in this case is how the objects in the CT scan is projected more posteriorly than it actually is. We thought the IOFB was at the level of the retina and searched internally, but it was actually at the level of suprachoroidal space. Thus, it is projected more posteriorly on the retina in the CT scan. A pre-planning of IOFB removal with the aid of CT scan is highlighted in this case. The retinal detachment in this case was managed with the silicone oil infusion. All cases are not necessarily superficial or over the retina, so that we can easily grasp it. They can be incarcerated deep subretinally even to the suprachoroidal space. Our next case is such a case. An anteriorly located such an IOFB can be removed externally. But posterior suprachoroidal IOFB has its own challenges. The most important point is to remember is a massive suprachoroidal bleed. Here the surgeon is attaining a proper hemostasis to aid the removal of IOFB using a laser and diathermy. Also, IOFB should be removed in a controlled manner and the infusion pressure should be kept high to avoid massive choroidal bleed. Thus, these three steps, diathermy, laser and high infusion pressure, helped us to avoid massive choroidal bleed in this case. Here, the surgeon is trying to remove the IOFB with a forceps. We can see that the IOFB is falling on the retina multiple times. If he had used a bimanual method, as we have discussed earlier, this could have been prevented. The take-home message in this case is the importance of a hemostasis in deep intraocular foreign body, and once again highlighting the importance of bimanual method.
Most of the foreign bodies with hammer chisel injury have this configuration. It is extremely difficult to hold them with any forceps. So another alternative that could be used is using a very high extrusion vacuum, because they generally have a very smooth surface. So it latches onto the foreign body and you can bring it in the AC if it is aphakia, and even if it's phakic, you can bring it just in the posterior, behind the posterior crystalline, behind the lens, and then you can focus, switch on the light of your microscope, deep focus, and hold on with the other hand and bring it out very easily. So it's a bimanual technique. You don't really need magnet also, and very helpful in this case. Trying to hold it onto the surface of retina is going to eventually cause this massive damage that happened in this case.
So you have very rightly shown the role of CT scan and ultrasound in the localizing of the foreign body. The large circular foreign body which you showed, was any ultrasound done for that patient?
No, ma'am. It was a CT scan done. It was the patient came with a report.
Okay. Because the ultrasound might have shown you the exact location of the foreign body, and you did not, because if it was in the pars plana, it would have been easily picked up by ultrasound. And the second foreign body, the suprachoroidal one, was again, was there any ultrasound or CT scan done for that? How did you exactly localize that
Ultrasound was
suprachoroidal
done.
position of the foreign body?
Ultrasound was done, ma'am. Yes, we would like to highlight that multimodal imaging with CT scan, even if present, we can do an ultrasound, and also in clear media cases, we have to take a fundus photo. Will be better for even if a medico-legal issue comes.
The suprachoroidal foreign body, actually, I would be more worried about full thickness, break, scleral break, because sometimes the foreign body might have gone through and through, or might have had a scleral perforation also. So you might end up with a posterior break or almost a hole, and sometimes it's very difficult because whatever you inject, silicone oil, etc., will all seep into the orbit. So that is a very challenging situation.
Yes, ma'am.
Okay, thank you very much.
Thank you.
So next, Srinivas, you want to present? Okay, next presenter is Srinivas M. Joshi. Seeing is believing, exploring new possibilities in vitreoretinal surgery.
Good afternoon, everyone. Thank you, respected judges. Can you play the video? Sound.
Seeing is believing. As technology. Now this video shows the high precision vitreous removal around the retinal vein with minimal cluttering of the retina. Can we identify which has the higher turbulence here, left or the right one? In fact, the parameter shows that the left is 10K and the right is 20K, indicating that both have similar turbulence. Now, looking into the digital filters, we have come now into the digital era. Several current techniques to aid visualization. Dyes that may have adverse clinical consequences. So the use of digital visualization may minimize the adverse effects of dye use via the digital color optimization. This is the case of BBG assisted ILM peeling being done. On shifting to monochrome filter, we can see that ILM is more clearly visualized even at diluted concentration of the BBG dye. You can see how nicely the edges of the ILM is being visualized with the help of these filters, minimizing the trauma to the retina in process of peeling. You can customize the color temperatures also from hot colors to the cool colors for the best visualization. This is the another case with the sub-ILM hemorrhage, and now when we shift to the monochrome, we can see the edges of the ILM being very well delineated so that the peeling process becomes easier. And now flushing out the sub-ILM altered hemorrhage. Now this is another case of PDR with extensive hemorrhage and the membranes. So here when we use the filter called as the reduced red color channel, it actually attenuates the bright red signal of the blood. Thus the membranes look more fluorescent. Dissecting these membranes become more easier with less or reduced iatrogenic breaks. We can use different color temperatures to improve further visualization. In similar surgery, having extensive membranes but with less blood, in these cases the green filter aids in increasing the contrast and proper visualization of tissue, which ensures the complete removal of the membranes. Here is another case of PDR where we are injecting a dilute concentration of fluorescein, that is 0.4 ml or 0.4%, consisting of staining the vitreous with diluted fluorescein to enhance its visibility, especially the stroma and the base. Now see how the vitreous is very well delineated. I change the colors to the normal and come back. I change to blue, change to green, change to the monochrome. But the best is the custom fluorescein angiography barrier filter, which is basically a red-free and the green-free filter. And now I am trying to dissect these membranes with the help of the cutter, flushing out the blood, and now doing a cutter segmentation with low vacuum and high cut rate, and now delaminating these membranes one by one. Fluid air exchange being done, and this is the 1 week post-operative image. Enhanced peripheral visualization, which is possible with the heads-up viewing system. This was a tile cutter presented to our emergency department at 12 in the midnight. A large foreign body with a piece of the tile cutting blade went inside and halved his eye. The foreign body was removed, measuring 14 to 11, and meticulously suturing was done. And it was taken for the VR surgery after 1 week. I thought it would be difficult to visualize through this small zone of clear cornea, but however, when I started doing the vitrectomy, finding the way through these membranes, a step-by-step vitrectomy was being done. PVD was reduced to the extent possible. PFCL was injected to flatten the retina. Retinectomy was done to relieve the anterior PVR, and finally clearing the subretinal hemorrhages. After injecting the PFCL back, we can see a well-settling retina. This is the site for sore eyes. Small zones of clear cornea, which we call it as window of hope. So these are the various cases which we could operate to the small zone of clear cornea. Thank you.
Thank you. Thank you very much.
Very good collection of cases. I did not understand how this injection of fluorescein in the vitreous will improve visualization.
It's, I don't say that it's the best kind of visualization to IVTA. Both are pretty much having a good visualization. Because there is a literature which has shown that the low dose of fluorescein, it stains the stroma and the base of the vitreous much better. So based on that, we tried using the chromovitrectomy, and definitely we need to have a little bit of filters for that to get the best visualization out of it. And we tried that, and both of them had pretty much similar effects.
And it is not toxic to the...
No, because we use it anyhow to the...
diluted form.
It is only 0.4%.
But are there any studies of the toxicity of
No.
fluorescein? No.
Not side. Because
Actually,
what we use actually is the 20%. So we have diluted taking 0.1 and diluting it to 20 ml. So what percentage we get is 0.4 to 0.5%.
To extract full use of fluorescein, you need an excitation
That is
wavelength.
for the intra-op fluorescein.
Yeah.
For intra-op angiography, in fact, we
No,
are...
not for angiography. Even if you want to say if it diffuses through the vitreous and if you want to visualize vitreous, then you need an excitation filter.
That's why we use the red free and the green free, and we promote only the blue light.
They won't excite. That is just a filter.
The blue light. The blue light
yeah,
excitation.
cobalt blue excitation.
The blue light excitation we use
The
it.
only thing left was ICG, I think, in your series. Can complete that.
Thank
Also,
you.
I think it would have been good to mention the parameters for the 20K vitrectomy in the
Yes,
video.
ma'am. Yes, ma'am.
Okay.
Thank you. Thank you very much.
So we come to the last presenter, Dr. Alok Sen, and his video is titled "On Block Resection of Capillary Hemangioma with Chorioretinectomy."
Can I have the video?
Endoresection of capillary hemangioma with chorioretinectomy. Retinal capillary hemangiomas are one of the earliest manifestations of the VHL disease. They can be solitary or multiple and may present small tumors in the periphery that are amenable to treatment with laser or cryoablation. However, large tumors often present with exudative, tractional or a combined retinal detachment and may require surgical intervention with en bloc dissection of the tumor, either transscleral or internal. Surgical removal of tumors may be challenging due to the high risk of intraoperative bleeding while resecting the highly vascular tumor. Similarly, postoperative proliferative vitreoretinopathy may lead to recurrent retinal detachment and surgical failures. Prophylactic chorioretinectomy was first described by Frank Kuhn in severe trauma cases for prevention of proliferative vitreoretinopathy. It has also been used successfully in cases of choroidal melanoma undergoing endoresection. In this video, we present a case of a large capillary hemangioma with retinal detachment which was managed by endoresection and chorioretinectomy. A 20-year-old male presented to us with diminution of vision in right eye since 5 months. There was a large retinal capillary hemangioma and a retinal detachment. On B scan, the retinal hemangioma appeared to be adhered to the choroid and there was evidence of retinal detachment. The patient was planned to undergo pars plana vitrectomy with endoresection of the tumor, endolaser and silicon oil injection. After achieving a posterior vitreous detachment and removing the cortical vitreous, the posterior retina was stabilized using perfluorocarbon liquid. A thorough dissection of the vitreous base followed this. The vitreous base was stained multiple times with triamcinolone acetonide to ensure complete removal. A 360-degree endocautery was performed around the tumor including the feeder vessels. The intraocular pressure was then raised to 60 millimeters mercury on the Constellation Vision system, following which the hemangioblastoma was removed piecemeal using the cutter. Since the tumor adhered to the choroid, a localized choroidectomy was also performed, leaving a bare sclera. Further hemostasis was achieved using endocautery. Fluid air exchange was done, followed by endolaser, and the case was closed under silicone oil. At 1 month follow-up, the retina remained attached with no evidence of proliferative vitreoretinopathy. To conclude, endoresection with chorioretinectomy can be safely done in patients with large retinal hemangioblastoma and retinal detachment, especially if the tumor is adherent to the underlying choroid. Thank you.
Thank you.
Yeah, very good, excellent case. But it's quite a risky surgery to do. And so I would like to know what was your indication for doing surgery in this case, and was that your first choice of treatment? Because the tumor was quite well away from macula was okay. Didn't seem to be,
it was a combined sort of retinal detachment, and that's why we went ahead to do the surgery. Although it was not clear on the first image that I showed, but if you could see the B scan, there was a complete retinal detachment, and even when we went in, there was a detachment. So we thought that it's a combined detachment. That was the reason why we took the patient.
Combined in the sense what?
There was because of traction and some retinal break rigma, which we could not identify pre-operatively.
But from the photos which you have shown, actually it does not look like a combined RD. In fact, in the photo, the macula looks quite attached.
Yeah,
so
it was not attached.
It was detached.
It was detached.
But even then, why was did you not think of doing some conservative treatment before?
Yeah, so we have now a series of cases. So some of the cases, what we did was we drained especially when there is exudative detachment, we drained externally and did cryo and put a saw. But in this case, because we were suspecting a regma, that's the reason we went in and do a complete vitrectomy.
So this case did not bleed, or you edited the part where it?
No, it did bleed a little. You could see some amount of.
That was the only.
That was that. It was not very much. We had raised the IOP to 68.
Even though it tends to bleed much more than what was there, you're very lucky.
Yeah, I may be lucky.
So generally, it is advised to use heavy cautery, the high voltage cautery. What was the cautery that you used?
So it was normal. We had used up to I had increased the cauterization power to more than 60 actually. Very high cautery I had used for the choroid. But still, sometimes the edges they still bleed, and you have to keep the pressures high. And even while infusing silicone oil, you have to keep it a little high.
Any other questions? Okay, so that
thank you.
Thank you very much. So thank you for your patient listening and for attending this session, and I thank the co-judges for their help. Thank you very much.